Okay, so this is category 1 within this first section. Okay, so this is the very first content area, integrating clinical psychopharmacology with the practice of psychology, and then this is a subcategory, 0, 1 meaning the first, and then the first one within the first. So we've got biopsychosocial variables that as determinants of medication effects, for example, age, gender, family history, patient belief systems, economics, social support, current environmental circumstances. So here's the question, because I want you to just try these things. Okay, so the biopsychosocial predictors of response to a particular medication might include all of the following. So this is one of those negative ones. Except patient's past response to the same or similar medication, family members' response to similar medication, therapist's school of thought, relative cost of the medication to the patient, its ability to pay, the patient's social support, and environmental stability. Okay, I mean, what was your natural inclination? Without everybody's going to pick C. Now I know you all had a peek. Okay, you would have chosen that. That makes sense. Okay, great. Too easy, exactly. Some of these are. Some of them you will disagree with. Okay, knowledge of relative effects of psychopharmacological and psychological interventions as sole, additive, or interactive treatments for given disorders. So, combined medication and psychotherapy. Treatment is likely to be optimum for which of the following conditions? Okay, bipolar, smoking cessation, substance abuse, anxieties, phobia, mania, acute agitation, dysthymia, personality disorders. So this is a combined medication psychotherapy treatment. Which of the conditions is it most likely to be optimal for? A, B. According to this, it's A. Yes, it's possible to overthink some of the answers. Yep. I like B, but I think it's A. It's A. Do you need, medication for treatment of a phobia necessarily? No, you don't. Right? Right. So it's saying likely to be optimal for which of the following? That's not necessary for phobia, right? Okay. Substance abuse seems contradictory for medication, but I think, right, and abuse could be a possibility. Right. There's also, they're not telling you which substance, right? So it could be alcohol, right? But it could be an opiate dependency where you have Suboxone or something like that. There's always room to debate, but unfortunately, one's going to be more right than the other. That's the way it's going to turn out. And you're going to have that experience when you're taking the PEP, but you could overthink it. So you have to make a choice, so do the best you can. You're not going to get them all right, okay? And if you can live with that, you'll be fine. These are I call these irritating questions because there isn't clear evidence one way or the other when you're thinking about it. So you have to make your best choice. Knowledge of relative effects of psychopharmacological and psychological interventions as sole, additive, blah, blah, blah. Okay. The use of benzodiazepines is not generally indicated in exposure therapy for phobia, alcohol withdrawal, medication-induced dystonia, acute stress response. I mean, everybody knows it's A, right? Because I left it wide open, right? What's the dystonia? That's an EPS condition where you have extreme tone, some problems with, I'm trying to think of a good example of it. Everybody knows generally what EPS is, right? You can get the akathisia, the dystonia is muscle tone disorders. You can get tremors, those types of things, okay? And medication-induced dystonia would be associated with what? Anybody know? Yeah, like muscle contractions, essentially. You can get very severe dystonias, like basically where your neck is wrenching around, turning in one direction, that type of thing. You can get severe muscle spasms in the upper back and neck area. They're really like large muscle contractions. But the idea of medication-induced dystonia is more commonly associated with what class of medicines? Antipsychotics, right? And in theory, it's going to be worse with the first generation, and the second generation should be a little better, right? While the evidence is less compelling in mild or acute forms, which following diagnosis is best treated by combination, psychotherapy and medication in its chronic form? So that's the key, in its chronic form. Now, you know there's controversy about what to do with the severe depression versus a mild depression, major depression, in terms of the role of psychotherapy, whether it has value or not. There's still controversy about this. It's not completely settled. I think some people think it's settled, but it's not. There's studies that contradict each other. So a recent study that came out that suggested that medication, most of the psychiatrists believe this. You give medication absolutely for severe depression. And I think everybody would agree with that. And even I have psychologists that I see that come in with severe depression, and they want to be on medication, right? But in terms of long-term benefit, it probably is true that therapy helps and is more effective. But it's also time-consuming, and it's also very expensive. I mean, you don't get well quickly. Sometimes, and you will see this when you start prescribing, the medicine really does work. It's not all bad, and sometimes you can really get a remarkable response, especially when somebody is presenting with very severe depression. And most of my patients have already had psychotherapy many times, and they have a remitting disorder. Not a remitting, but the other way around. They have a recurrent illness that just doesn't go away completely. And even sometimes meds fail significantly when you try to help them. But I believe that therapy is important, but in the nature of your work, you may not have as much time because you may find you're seeing sicker people and handling other types of disease entities than you are used to. And in that way, you end up doing a little work like a psychiatrist in a way. But I think our approach to the communication with patients, I think psychologists they generally handle that differently. Not all, not everybody. But I think most psychologists are relatively aware of the role of therapy, and they try to, even if you can't see the patient as regularly, you're always going to try to do something along those lines to help them. But there are controversies about that, and it's not completely settled. So a takeaway message about this category here is generally they want you to include psychotherapy, okay? And where it seems to be justified, you want to do that. That's just generally a take-home thing, that there's a feeling that they really want you to pay attention to that, okay? They think that's a very important component of treatment, and that is true. Okay, what is this? Psychotherapy. In general, psychotherapy is less effective as a single modality than pharmacotherapy when treated chronic depression with Axis II disorder. Pharmacotherapy is less effective as single modality approach than psychotherapy when treating chronic depression with an Axis II disorder. There is no difference between psychotherapy and pharmacotherapy as a single modality treatment for chronic depression with Axis II disorder. Combination therapy should always be used when treating depression. Okay, and the answer is B according to this, right? Okay, anybody have any issues with that? And, if you have somebody that, like a bipolar patient, not a 2, but a 1, therapy is going to help them, but your real lion's share of work is going to be getting something that controls that severe mood disorder. And that's always complicated, and it's not quite like you can just give them one thing. So as you do this, and as you see more pathology, you're going to find yourself using multiple meds. It just happens. because oftentimes one med is not sufficient. And I'm talking about more severe disorders. I'm not talking about some mild depression or even moderate depression. I'm talking about, you know, a very severe mood disorder. Can't really medicate an axis 2. That's right. I don't think there's good evidence for that, but I know that some of that is being done. Okay, and treatment, this is limitations. This is a new category. Limitations and benefits, patient's perception and treatment expectations regarding psychopharmacological and psychological interventions as sole, additive, or interactive treatments for a given disorder and functional impairments. In the treatment of OCD, okay, research indicates that single treatment modality behavioral therapy is more effective than combination treatment modality when symptoms are primarily compulsive. Research indicates that combined treatment modality medication behavioral therapy is more effective than single treatment modality when symptoms are primarily obsessive. Research cannot provide any direction regarding the choice of single or combined modality treatment. So they're saying, and everyone here is saying, both A and B are correct, right? Limitations and benefits, patient's perception and treatment, same category because we're 01, 02. A patient's preference for an anxiolytic to address anxiety symptoms associated with depression. A patient's preference for an anxiolytic to address anxiety symptoms associated with depression is a minor factor but needs to be considered in treatment choice, is a significant factor when selecting treatment, should be overruled if research suggests a more effective treatment, both A and C. Now, what do you all think? We only have a couple more minutes. What's the issue here, obviously? Anything? Well, B is the answer, we know that, but why? Patient compliance, that's a good one, okay. There's a patient preference. If you disagree with them, you really have to provide them with a rational reason why that would not work, right? The patient's motivation is if the patient feels that you've heard what their request is and you understand it and you think it's reasonable, they're more likely to be compliant, they're going to be more satisfied with the treatment. That's a nice little placebo effect. That's correct, okay? Impact of belief on efficacy is very, very important, okay? Okay, but the question does say to address anxiety symptoms. So the patient's preference for an anxiolytic to address anxiety symptoms. And when we say anxiolytic, we typically mean what? A benzo, yes. Yes, a benzo, right? And there is a bit of a problem, right? Because we learned that sometimes benzos, particularly a benzo with somebody who's depressed, could be a potential issue, right? Because we're taught that benzodiazepines can exacerbate depression, right? Everybody's heard that. I'm sure you've heard that, right? Yeah, okay. So that's kind of a funky question in that regard.